Purvi?
Yes, ma'am. Shall I start? Okay. Good evening, everyone. Today is Searchlight 33. Number 33 is for cervix. So I welcome you all on this enlightenment. Today we will have great discussion, great faculty, great speakers, and we will discuss about the updates on Gynac cervix. I would like to introduce our program director, Dr. Asha Jain, ma'am. Ma'am is a director of SMSA Hospital in Raipur. She is medical director, Cancer Prevention and Relief Society. Many academics, many laurels, many training onto her name. She has special interest in colposcopy, saving the uterus, fetal medicine, and Obgyn ultrasound. Ma'am wants your support for voting for chairperson for Food Drug Committee and MSc Committee. Over to you, ma'am.
Thank you so much, Purvi. Namaskar, everyone. As always, we take the blessings of the divine before we take the program forward. So, just a second.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युमामृतं
I welcome you all to this 33rd edition of Searchlight. It is on the Gynac cervix, where the Searchlight is focused today. We are all talking of preterm labor and the obstetric cervix, but here the topic is the Gynac cervix. We will today in the lectures learn to look at it through the ultrasound, through colposcope, and also through hysteroscope. That is the target today, and we'll have a panel accordingly. The societies which have contributed members to us in this program are Akluj, Alwar, Baramati, Bhopal, Chandigarh, Kotkapura, Nadiad, Nizamabad, Northern India, Patan, Palakkad, Raipur, Ganganagar, Srikakulam, Virudhunagar, and Yamuna obstetric gynec societies. I would like to welcome my convener, Dr. Sujayasri Sangita, who's the secretary of Bhimavaram Obstetric Gynec Society. She has 2 hospitals, and unfortunately, just now she had 3 cesareans and she could not join right now. She has the Shane Ratnam Young Gynec Award, Foxy Dhira Award, is interested in laparoscopy and infertility, does a lot of community work, and has been associated with me since Searchlight 6. I would also like to introduce my coordinator, Dr. Purvi Agrawal. She is an MBBS DNB. She is a fetal medicine specialist trained under Dr. Adi Narayan. She's been helping me off and on whenever I have needed her, she's always there. She's a director and consultant fetal medicine at Krishna Fetal Medicine Center. She's an executive member of Society of Fetal Medicine Chhattisgarh, past IFS executive, IOTA and FMF certified. She's trained in fetal procedures and has many national and international publications. In the training at my hospital for Foxy, she is a co-trainer. So welcome, Purvi. Dr. Narendra Malhotra sir has not yet joined us because he is in another program and he would join us a little later. He's our guest of honor. So I would like to introduce with great love and respect, Dr. Sushil Kumar Giri sir. He is here as our guest of honor. He has worked on the cervix and other gynec organs all his life. He is an ex-professor, PG Department of Gynec Oncology, former director at AH Postgraduate Institute of Cancer, Qatar, male. He has ICOG oration at Thrissur Subodh Mitra Memorial Oration, Kolkata. I think this award list is small because he's never seeking an award. He's been such a fantastic teacher and a person who's been working for women's health. He's a peer reviewer of Gynec Oncology, Indian Journal of Surgical Oncology, Journal of Global Oncology. He was the president of Association of Gynec Oncology of India in 2007-2009. Years back, when I was doing a study on HPV genotype in India, sir provided a lot of samples to me so that WHO study could be completed properly. I'm ever indebted to him. Respected sir, I welcome you
Thank
for
you.
your words of blessings.
Thank you very much.
Yes. So we are waiting to hear from you, sir.
Okay. So good evening, everybody. Am I audible now?
Yes, sir.
So I'm thankful to Dr. Asha and her team for asking me to be here. Yes, this is the Searchlite 33, and she is continuously doing the academic activities, and this is the 33rd episodes of her activities in different gynecological diseases and obstetrical diseases also. So I'm really thankful to her and her team for effortless and continuous effort for helping the poor women of this country. And once the last few months, 1 or 2 months back, I was there at Raipur also for this ICCP conference, and fantastic work done by Dr. Asha and his and her team. And regarding this, today's topic is cervix. Cervix is an organ which is very easily one can see and assess, but yes, it is less done. And that's why nowadays we see a lot of diseases, that is precancerous diseases, are happening in our country, and we are not very much aware of it, and we do not take care of the poor women who is suffering from the diseases. And still we'll be discussing and we'll be knowing about from the before birth till the end of the life, the service development, the congenital anomaly, and all these things. And I like to listen from you, the different speakers who are ready to give us different knowledge of cervix from congenital, from birth till death, you can say. So cervix is a neglected organ of the body, but it is the most important organ from starting from it is from congenital diseases and some diseases of that is cervix can almost all diseases can occur in cervix, from tuberculosis, cancers, precancerous lesions, on cysts, ectopic, all things can come. And most probably Dr. Asha will be with her team and their speakers, they will be deliberating all these things to us, and I'm waiting for the deliverers to update and my knowledge. And thank you for Asha for asking me to be here in this August gathering. Thank you so much.
Thank you, sir. It's such a honor to have you here. Talking of the cervix and you're not there, I can't even think of it. So thank you so much for accepting my invitation. If you stay in the program, it's fine.
I'm
sir.
there. I'm there. Sir.
Thank you, sir. Thank you, sir. Next, I have my dear friend, Dr. Priya Ganeshkumar. She is the chairperson of Gynac Oncology Committee, FOXY, medical director of Sainevas Healthcare. It's a chain of preventive oncology centers, pan-India. She has done a lot of mentorship and training for colposcopy, spreading awareness for WHO, IARC, IFCPC colposcopy and cytology course trainer. She's trained more than 1,000 gynecologists so far, official master trainer for cancer prevention under NCD Ayushman Bharat project, and a PhD guide for Bharati Vidyapeeth University, Pune. She has many books. She has a couple of books on colposcopy, many awards, and she has many key positions that she has held. Chairperson, National FOXY Onco Conference, National Coordinator, FOXY IAP HPV Vaccination Project, ex-PNDT Chairperson Thane, member of core team, invited by President of Malawi, East Africa for MMR, organizing secretary, National FOXY RCOG Preventive Oncology Conference in Goa. She also did a fantastic oncology conference in Thane last year. So welcome, Dr. Priya. We are really happy to see you here, and we would be grateful for your words.
Thank you, Dr. Asha. So indeed, it's my pleasure to be in the Searchlight, and I'm seeing it's number 33. So this is showing the true academics and the academic feast which you are giving to the Foxians every week. And today you have taken cervix as the topic, and the topics are also well designed. Because many of the Foxians are doing sonography, and then we have to also understand, we are only talking cervix and colposcopy. Cervix with hysteroscopy, again, a beautiful topic. Cervix with sonography, again, eye-opening topic. So you have chosen the topics very well, and I'm sure this Searchlight program is going to throw a real light on the things which has to be understood. And all the best to your this thing. And I know Asha since long, a dedicated worker, a dedicated academician, and a true noble soul. So all the best for your future endeavors, Asha, and for the upcoming elections. So I think the topics are extremely good, and I don't want to waste time in this thing. So all the best. Let's start your program. Yeah.
Thank you so much. In the end, we have Dr. MC Patel, sir. He is a consultant obstetrician gynecologist, medico-legal counselor. This whole CV is there, but more importantly, he's standing for President Foxy this year. Election starts tomorrow morning at 10 a.m. I invite sir to say a few words for this webinar and for his election before we take the program forward. Welcome, sir. Patel, sir?
Yes. Thank you, Dr. Asha. Only 1 minute. Yeah, am I audible?
Yes, sir.
Yes. So let me congratulate first Dr. Asha Jain for spreading knowledge through her Searchlight program, and this is its 33rd program, and she's discussing very focused topic every time, and she invites very eminent faculty in respective field. And today she has selected a very interesting topic related to cervix and cervical pathology to discuss in our day-to-day practice how it is relevant. It is also very important part. So she has selected all the learned speaker, legend in their respective field, Dr. Raju Giraddi, Dr. Rimpi Singla, and Dr. Pushpavati Thakur. They are going to discuss very important topic related to cervix by ultrasound, cervix through colposcope, and microcolpohysteroscopy. And at the end, Asha could. Herself is going to moderate very interesting panel related to case-based scenario as far as cervical pathology is concerned. But which we are much more concerned to cervical cancer, because by 2030, WHO and Government of India has given a target to eradicate cervical cancer from India. And now they have come up with 90, 70, 90. That is 90% vaccination to prevent, then 70% early detection, and 90% meticulous management whenever patient comes to us in any stage of the disease. But second part, that is 70% screening part is concerned. It is very important part, and how different tools can be useful in that very screening part is also important part. So cervix is a very important organ, rightly said by Dr. Giri just now, and naturally it is ignored organ, but equally important, and we should be careful as far as any cervical pathology is concerned, whether it is benign or whether it is malignant. So congratulating Dr. Asha Jain again for inviting me to this very important webinar related to cervix. Thank you very much, Asha.
Sir, I would like to give you the all the best for our coming election from tomorrow, dear friends. Please, please, one thing which I really want to tell you all is, as the academics are important, equal important is the right people coming up on the, on the position, so that the academics and absolutely, Dr. MC Sir Patel Sir, who has been a true friend of everyone when it comes to medical legal aspect. So it is now the time to repay. Sir has been actually working very hard for Foxians, we all know. And he is a true grassroots level person. He has been connected very, very well, intensely with all the people in the society.
Yes.
It is only the way how we can repay is by doing voting. What happens is people all say, yes, we know, sir. Yes, everything is correct. But unless and until you open up your app and then you don't vote, what is the point, right? So I urge very humbly, we have wonderful people on the team this time who has been opting for elections, and it is our time to repay them and see to it that they are coming on board of Foxy. So all the best to you, Dr. MC Patel, sir, and Dr. Asha Jain, and please continue.
Yes.
Thank you so
Thank
much,
you.
Priya.
Thank you,
You
Priya,
said
for
a lot of things that I would have loved to say. Sir
Yes.
has been working for medical legal health of all Foxians for 14 years. 14 years. So please, he is consistent and approachable. So please vote for him, and voting starts tomorrow 10 a.m. Please vote.
Thank you.
And ask your friends to vote as well. Sir, if you have other work, you're free to leave. I just wanted you to be here one day before your election. So
Yes.
thank you so much for being
Thank
here.
you.
All
Thank
the
you,
best,
Asha.
sir.
And
All the best, sir.
yes, Nisi.
Yes, sir.
So it is my humble appeal to all the
We are
delegates
with
who
you.
have
No
joined.
problem. We are there. We are there.
So working in Foxy since years together, now I have paid my candidature for President Foxy, and consider my seniority, sincerity, dedication, and easily availability to any Foxian friends in any odd medical legal crisis. I am always available, and I humbly appeal to all of you to consider my candidature and to cast your precious vote in my favor for the post of President Foxy. Thank you very much.
Thank you, sir. Thank you. Purvi, if you would please introduce our chairpersons of the first session. Thank you, Patel, sir. Thank you, Giri, sir. Thank you, Dr. Priya. If you can spare the time to listen to the first lecture, I will be really grateful. But if you have another webinar, I know, then I think you can choose to leave as well. Thank you so much.
Okay, so now we move on to our first session, which is Cervix by Ultrasound by Raju Giraddi, sir, for which I would like to invite our chairpersons. Firstly, I would like to invite Dr. Emmy Globin, ma'am. She is the president of Palakkad Obstetrics and Gynecological Society. Then I would like to invite Dr. Uma Maheshwari, ma'am. Ma'am is director of Ashok Hospital, Karapnagar, Virushka Infertility Center. And then I would like to invite Dr. Jatinder Chadda, madam. She is a gynecologist in Gandhi Medical College, Bhopal. Ma'am is president of Yamuna Nagar Obs and Gynac Society, and she has many past experiences in laparoscopic surgery at Srijan Test Tube Baby Center, and she is a member of Foxy ISAR IS.
I don't know if any of them are present here. Any of the chairpersons present here? Purvi, would you go ahead and introduce, sir?
Yes, ma'am. For the first session, I would like to invite our speaker, Dr. Raju Giraddi, sir. Sir is a junior consultant in Betadur Super Speciality Hospital, Raichur. His areas of interest is pelvic imaging and fetal medicine. Sir is an excellent ultrasound specialist, especially for gynec imaging. Very warm welcome, sir. Over to you.
Thank you. Thank you so much, ma'am. Can I share my screen?
Yes, sir.
Is it seen, ma'am?
Yes, sir. It's seen.
Yes.
1 second. Oh, it's getting.
Sir, I'm Dr. Uma Mishri. I congratulate the team and welcome you, sir. Thank you, sir.
Namaste. Good evening, everyone. At the very onset, I would like to thank Dr. Asha ma'am for giving me this wonderful opportunity. I'm really honored to be in this wonderful platform of Searchlight, where this education light has been continuously throwing so much of knowledge across. And this is 33rd session. Thank you so much, ma'am, for the invitation and giving me this opportunity. And I should also thank Dr. Purvi, ma'am. She is my senior and mentor in fetal medicine. I'm very grateful to you, ma'am, for giving me this opportunity. Thank you, ma'am. My first slide is seen, ma'am.
Yes, sir. It is seen.
Yes, sir.
Yeah. So we all know that cervix is one part of that uterus, which is easily seen actually if you do a per vaginal examination with the speculum. Part of it is seen, which is the external os and the lips and all, but inside part of it is we actually miss. So we are more often not doing a particular clinical examination in most cases. We are often missing so much of pathologies, especially the benign ones, which are not there, which are seen to the outside world. But how is that? Because ultrasound, we know how helpful it is in diagnosing many of those things and giving us a picture that what the surgeon to be need or the consultant has to go further with the diagnosis that is there. So we all know TAS and TVS are complementary to each other, but I'm choosing TVS for the very simple approach because the optimization of the image is very good in that. So as the word hysteroscope goes, it is actually a misnomer because we do hysteroscopy. We start doing it from the vagina, from the introitus. That is it, from the introitus. We look into the vagina, then we go and look the cervix, then the corpus. So in the same way, but when we go into the terminology for transvaginal sonography, I know that most of us, we only screen upper corpus, at the most at the cervix, at the most in the upper part of the cervix. We are not actually imaging the total of this. So we need to do scans. So this is how I would like to begin my basic approach of doing a transvaginal sonography. Here, my probe is at the introitus, and this is the bladder here. I'm trying to slide across slowly into the vagina and then hit the anterior fornix. So once I do this, look here, my sector width is almost 180 degrees so that I can see the uterus in its entirety. So once I do that, I take my focal zone to that point area, and also the region of interest is covering almost 80%. So now as I've done through the vagina, I take into the cervix. So from here, I move ahead. For to be more specific, I try to place the probe in the anterior fornix. This is the bladder wall. This is vesicovaginal fold. This is the anterior fornix. So I'm imaging the cervix proper. So cervix looks like in sagittal plane, it looks like a cylindrical organ. Here you can see the anterior lip of cervix, the posterior lip of cervix. This is the external os and the endocervical canal. So this is how we need to begin our transvaginal sonography. As we know that we have a checklist for most of our fetal medicine things like first, second, third trimester. For also this to be more better, so that will not miss this usually missed entity. We heard it in the last lecture that placenta is the most neglected. In the same way, cervix is also one of the most neglected entities. Anything that you see, you try to put colors at PR of 0.3, which is the principle in Gynac imaging at low PRF and low wall motion filters. See, cervix, the stroma as well as the endocervical canal are usually avascular, and maybe because of the movements you are able to see with these smaller vessels that are seen. So what is that we most of us do? We do scans like this where we have our sector width which is very less, and we are only concentrating on the upper part of the uterus, that is the corpus. We neglect the cervix. So what is that we need to do? You can take across to the whole length, that is 180 degrees, and keep your focal zone such that we are going to image that area of interest, and take enough depth such that I'm going to image the area of interest. So here it is the cervix that I'm imaging. I'm trying to look at the external os, the anterior lip of cervix. I'm using the probe pressures here. That is very important. Why? Because in cervix, if at all you have a lesion within the endocervical canal, if it is popping out or moving out, then that is more likely an endocervical pathology rather than the stromal pathology. So these are dynamic scans that we need, that we can definitely do in TVS, but that we cannot do it in transabdominal scan. This is how we assess the cervix. So yes, even if your sector width is very low, so that your frequency is going high, but still you keep at least bring the region of interest. Don't neglect the cervix. The cervix, it has its own dynamic phases. At different phases, you can look at the endocervical, the stripes that are seen there. These are normal physiological ones. So this is in case of a menstruation, where because of little fluid, you are able to appreciate the stromal linings. So now we'll go with some pathologies. These are very common ones, the benign ones we often see in almost all scans that we do, almost all, majority. These are anechoic cystic lesions, which are there more common towards the endocervical linings and just periphery to that. So these are the Nabothian cysts. These are usually avascular. It doesn't, they need not be always near the stromal lining. They can be into the endocervical lining. They can be into the stroma also. So this is how we need to assess. Here in this case, I have this case as a previous cesarean. How to differentiate that from the scar defect? So usually the anechoic lesions of these Nabothians that are there, they don't have an hyperechoic shading, which is usually be there with the isthmocele because of fibrosis. So that is how we can differentiate that. And also the lesions will be way below the scar area. So what is the mistake that I'm trying to do when I do the scan like this? Here I'm only concentrating more on the corpus and the lower corpus. So if I would have done a systemic scan where, okay, I've come back, if I start doing a systemic scan in every patient like this, so you are able to see the anterior fornix here. This is the anterior lip of cervix, the posterior lip of cervix. What is that you are seeing in between? You are able to see a hyperechoic stalk-like thing, which is protruding out to the external os. So this is what, these are all benign lesions to say. This is a simple case of the endocervical polyp, which is popping out. So if you start doing your scans in a systemic manner, definitely you will not miss these pathologies. Because see, suppose if you are only evaluating this patient, even if she's having a polyp here, and you start doing evaluation for her infertility aspect, and then you will start giving her triggers, maybe this is going to hinder the normal physiology that is going to take place later. So this is how, once you have located the polyp there, it's always, I was trying to tell you that you always put color, so that I'm trying to put color to know from where exactly the stalk is coming from. Is it coming from the upper body, upper cervical canal, or is it reaching into the endometrial cavity in the upper corpus? So this is how a stalk, your Doppler will play an important role to tell us from where exactly it is coming. So if it was a smaller one beginning from here, then definitely that would have been an OPD procedure to pluck it out or avulse it. So this is how we need. The same case when you look into the hysteroscopic view, this is what you are seeing, a polyp, a benign lesion polyp, which is popping out from the endocervical canal through the external and then into the external os. So again, yet another cases to show. Here I am into the vagina. I hit, this is the urethra. This is a bladder. I hit a lesion here. You can appreciate a lesion here. This lesion is though isoechoic to the rest of the echoes here, but it is a bit circumscribed. And you can see this is the anterior lip of cervix. This is a posterior lip of cervix. And I'm trying to see the corpus here. So you are able to see the endometrial lining very neatly in the upper part, which is some polyps over here. But here you are able to see the black line, the anechoic kind of thing, which is in continuous with that lesion here. This is likely to be a lesion which is arising from the upper corpus. And here you are seeing the lesion which is say popping out from the both lips of the cervix into the external os. So this is likely a case of polyp. And what I'm trying to do is putting my probe pressure such that this lesion, when I'm trying to assess whether it is a benign lesion. See, with probe pressures, it is going to move, and you can apply pressure such that there is a compressibility of this lesion. So the same case when I did some maneuvers to antivert the uterus and I put a color. So this long stalk-like pedicle, which is actually arising from the upper corpus. This is how we need to assess any lesion which is popping out. Try to use your color and try to know from where. This cannot be an OPD procedure now. So this is a fibroid polyp that was actually, this is a polyp that is actually protruding out for the external os. And so we can assess and give the surgeon the better diagnosis that this is likely coming from a stalk which is there, which is having its beginning from the upper corpus. So when you try to see multiple polyps or small polyps, always look for other areas of polyps. When you have seen in the upper corpus, try to look for smaller polyps like this, which can stand out in the endocervical canal. Why am I stressing on these points is that we are usually actually missing these. Suppose if this patient goes for IUI later, the IUI catheter may actually get blocked by this. So these endocervical polyps, these though they are very benign lesions that can be easily managed by hysteroscope, and you are able to appreciate that. So these things are needed to look into. So that was about polyp. Now some more pathological lesions. You are able to appreciate a circumscribed lesion there, which is there in the posterior wall of the cervical lip. This is the anterior lip. So you are able to appreciate, I am able to trace the endocervical lining in anterior, which is snugly fitting onto this anterior border, and which is going continuous with the endometrial cavity, this lining. So I know I have mapped this, that there is a cervical fibroid that is arising from the stromal part there, and sitting in the posterior lip of cervix, a large fibroid. So, and also whether with my mapping, am I able to tell the surgeon that this has to be approached peritoneally, or you can do it by doing just by vaginal approach and giving a nick on the posterior lip of cervix and then removing that. So this is how a fibroid looks. A fibroid appears to be well circumscribed. It may look varied because of this. The fibroid in case of a cervix looks different from that of a myometrium, where it can have different stromal fibers, and you can appreciate the capsular uptake. It can also have intralesional vascularity. So the capsular uptake of the capsular uptake is classical for a fibroid. So here you can appreciate a large, this is the corpus, this is the fundus, this is endometrial cavity, a large lesion. This is transabdominal sonography, a old video. So here you can appreciate a large fibroid which is sitting there in the cervix. Definitely, I would not have been able to image the upper part of the corpus if I do a TVS. So in such cases, when you have a large cervical fibroid which is sitting there, what we describe this as a lantern on the dome of St. Peter's Cathedral. So this is how a large fibroid can be appreciated. Some more lesions to say here. This patient had severe pain and dysmenorrhea when I was trying to look into the cervix, and a hypoechoic lesion with few echogenic lesions within the lesion we are able to see, and this was associated with endometriomas there. So likely this is a case I want to show you that this differentiates from a Nabothian. So you have these hyperechoic plex there in the borders, and the internal echoes are of that low intensity like an endometrioma. This is a case of cervical endometrioma. So this case was also associated with the significant adnexal pathology. One of that was very closer to that was the uterosacral nodule that you are able to appreciate here, a uterosacral nodule, an endometriotic nodule in the same case. So large endometrioma was there on the right ovary. This is actually an uterosacral nodule. So spanning across your, doing a systemic scan and spanning across the major organs will definitely, yes. Yet another case to show, this patient had severe dysmenorrhea and she had instrumentation in the previous MTPs, and this is what was happening in the next. Here there is hematometra inside, and you can see in the cervical canal a bit of more echogenic lesions in the upper cervical canal near the isthmic region, likely to be associated with fibrosis there, and it's causing cervical stenosis, and you have hematometra now. So these lesions can definitely be dealt now with a hysteroscope and a scissor, and you can evacuate this easily. So these are how we look into the cervical lesions. Why am I bringing this here is HSD is what it looks to be an unicornate uterus, but this is not the end of it. We go and do 3D, and this is what I get for the same case. What has happened here? My Leach-Wilkinson cannula has entered to one of the endometrial cavities, and we are able to image only this part. So you can appreciate there is only one external os. My Leach-Wilkinson cannula entered there. So now what is the importance of imaging in 3D, especially looking at the lower part? See here, I'm trying to image only the lower part. This is the cervix. This is the external os. And this is one canal over here, and this is another canal. The septa is actually beginning just above the external os. So this is to show and tell the surgeon there is a cervical septa, but it is not up to. So if there were bifid cervix, definitely I would have seen while doing the HSD procedure as two well-defined cervical cavities. So now because it was one, I entered here. That was because I overshooted the septa. So this is how a 3D will help. The same case was to show in endoscopy where there was a single external os, and we could appreciate that there was a septa that was beginning just above the external os. So our clinical, our ultrasound correlations in our endoscopy team is helping me most of the times to go and retrospectively learn. These are the stroma of the endocervical glands that you see, the endocervical glands. This is actually the septa that was onto the left side, that was onto the right side cavity, that was leading onto the right side cavity. Here you have another cavity. This is a case of complete septate uterus, whereas the septa is beginning just above the cervical os. This was the surgery that was done. So in this case, it's very neatly seen that you have two well-defined cervical canals with the bifid cervix that you see. This is the vaginal view. So what is the importance of doing such cases? I'll try to tell you. What happens sometimes in 2D, you may fall. This is in my transverse plane. I'm looking at the cervix. In my transverse plane, I was not able to define the cervical canal. I'm able to appreciate one. I'm sorry for the interface, lot of interface. So you are able to appreciate one canal over here and another canal over here, but I was not able to see whether there is single external os. So you can utilize your 3D here. In my dual plane, this is the acquisition plane, and with the view line, you can see the corresponding, this is the external os. As I go down, you are able to see the external os. As I go below inside, as if I do a hysteroscope, I am able to see a septa which is beginning just below, just underneath or just into the cervical canal as I go. So this is a case of single septate, single cervical os, but a septa which is beginning from the cervical canal itself. So this is how 3D will definitely help. Why is it I'm stressing this case? When I do a 3D for the same, you are able to appreciate that the septa is beginning just above that. So cervical canal, I do 3D upper corpus separate, lower corpus separate in times of when I have a difficulty. Why is it so? Because if you look at these two cases, which are rare cases, actually, you have a single external os, but a septa is there dividing the cervix. So in such cases, we may have to cut only this part of the cervix and this part of the septa. Whereas in such cases where you have two well-defined bifid cervix, so the management differs because most of them don't like to cut the septa, they only have to widen this cavity. So you not touch upon the bifid cervix. For example, in this case, you are able to appreciate the two well-defined cervical entities with a fibrous band in between. So this will help me to tell the surgeon, okay, there are two well-defined well-defined bifid cervical cavities that are there. This also helps me to tell that we need to look further whether are we missing a vaginal septa in this case. This case actually had a vaginal septa, which is not very easily seen in transvaginal sonography, because when both the vaginal canals are patent, one side when I put the probe, the other will be collapsed. So that is how. So we'll move ahead with some more pathological lesions that we need to see. Yeah, what is that I'm trying to show? Here you may get confused with the Nepothian cysts, which are more likely seen at the level of the isthmic region and near to the endocervical lining. But look here, actually this is a case of previous LSCS, and if you closely observe how it differs from a Nepothian cyst, they have hyperechoic edges. And that is what I'm trying to show you. This is a case of isthmocele, which we call now as one of the entities. There are classifications for that. Now, this is one of the complex isthmocele that we have. We have multiple cystic lesions. So we all think that isthmocele have to be defined only in the sagittal plane. No, we have to go transverse and see, you see those multiple cystic spaces that are getting interconnected to the lesions there at this level of the previous scar site. So we may get confused. Sometimes a cyst can help define that whether am I dealing with the isthmocele or it is actually an Ebothian cyst. But even your 2D itself with having characteristic hyperechoic borders will tell us that it is a isthmocele. So early pregnancy, UPT positive, good that she had come early, not a case of previous LSCs, just I have ruled out to say that. But look here, in the cervical canal, you are able to see a gestational sac with a yolk sac that is there at just 5 weeks or 4 days, no fetal pole yet. So yes, cervical pregnancies are not uncommon, but definitely when you pick up early, you need to intervene. This intervention will be helpful for us to deal with it with less complications. If it would have grown bigger, you would have seen an hourglass appearance that is classically seen in any cervical pregnancy. Early ones are the better ones to deal with. I will move into the few more last slides where I'm trying to show you a cervix here, but a large, irregular, not defined, ill-defined lesion, which is isoechoic to the rest of the echoes here. The uterus is retroverted. This is the endometrial cavity. This is a but look here, the posterior lip of cervix is showing this ill-defined lesion there and a large mass which is sitting. This patient presented with PV bleed and the white discharge as well. She is 56, 60 years of age. With this is what we are trying to look at. Look, the lesion, when I put color, this is showing hypervascularity. This is a case of CA cervix. So these entities are actually not for a clinician, like a physician for us. We actually do PV and definitely do a per-speculum examination for such cases so that we'll not miss these lesions, which are obvious for the external world. You may have to depend on ultrasound when you have a very small lesion within the endocervical, within the cervical canal or on the stroma. But the studies are very less to see that we can pick up early precancerous lesions. I'm thankful to my sir and mentor, Dr. Varun sir, has shared a few more clips on the CA cervix lesions, ill-defined lesions which stand out to be hypoechoic sometimes, and they are hypervascular. And he has shown us a demonstration of doing an elastography, what we are trying to show here. This picture is trying to show on elastography the shear strain of the lesion that you are going to see. The more the bluer you are going to get, it is going to tell you that it is more harder. So it is getting harder. So the more the red you get, it has become soft. So you can use this entity to define whenever you're in doubtful, apart from the vascularity, whether it is a polyp or whether it is a hard substance. Maybe by the subjective feel, by doing a transvaginal sonography also, you will be able to appreciate, but shear strain of this method of using elastography does help in looking out the carcinomas as well. These are hypervascular lesions that are there. Some more entities when patient presents with pain, abdomen, dysmenorrhea sometimes and white discharge PV. Here you can see a multiparous lady who was presented with now when doing a per speculum, we are able to see a very thickened and hypertrophied cervix. So what is that I'm trying to show you? You are able to see there are few Nebothian cysts and also the endocervical linings are showing some hyperechoic flex in the stroma as well. And definitely when you put color, what is trying to tell you is about the inflammation, whether this lesion is having, whether this cervix is having. So play with your colors to know more about it. See, definitely in my normal case, when I showed in the first few slides, it was not vascular as this. So it is more vascular. So cervicitis is an entity which we do make diagnosis by clinical examination, but sometimes though ultrasound is not those specific, to always say it is a cervicitis, but definitely hypervascularity, when we have checked in, we need to look for. And how do I differentiate this from a cancerous lesion? This echo is within the echo of the rest of the echoes, and there is no ill-defined borders or no overgrowth. So this is how we can look into the cervix entity, start doing a scans in a systemic manner so that we'll scan every cervix before we look into the uterus. Thank you. This is what I was trying to show the part of it in my ultrasound in looking for the cervix. Thank you, ma'am.
Sir, it was a good presentation, sir. We are all enjoying your scan pictures. I'm Dr. Uma Mishri from Virudhunagar district, sir. It is a very great lecture, and we are very benefited by your ultrasound pictures, sir. Very nice, sir. We are blessed, sir. Thank you, sir.
Thank you. Thank you, ma'am.
Giri, sir, you have been listening. Would you like to say something?
Yeah, so nicely, he demonstrated the real pictures of cervical regions and that is anomalies and regions. So it is really eye-opening. And we send to the ultrasoundologists, they do what they feel like doing. But it is if you're yourself doing ultrasound and doing with dedications, most probably you will get the diagnosis from the very beginning and treat accordingly. Thank you, Dr. Raju, for your nice deliberations and yes, thank you.
நான் பேசிட்டேன்.
Thank you so much, sir. Thank you, sir.
பிள்ளைங்க salary போட்டோம் ஓடியா. அது தெரியாம அடிக்குதா? கண்ணு தெரியுமா?
You know, I learned my ultrasound from Dr. Mala Sibbal, and she always says that when it is cervicitis, there will be an increase in vascularity, but the vessel pattern will be different. When it is a malignancy, always it is the vascular pattern, that is, you have vessels which do not follow a pattern, that is a pattern of malignancy.
Yes,
And
ma'am.
in cervicitis, the regular cervical pattern will be maintained.
Correct.
That is very important, because any polyp, like even in endometrial carcinoma or a carcinoma in a endometrial polyp, the way we differentiate is by the vasculature. So if it is a regular vessel, a single vessel, then it is considered benign. But if it is multiple vessels which just come from nowhere, you cannot see them come branching or anything, in that case we consider that to be suspicious and to be further investigated.
Thank you. Yes, ma'am. Thank you so much.
Thank you so very much, Dr. Raju. You actually did justice to the topic. And now over to you, Purvi.
Yes, ma'am.
Over to you.
It was a great talk, sir. Thank you so
Thank you,
much for
ma'am.
accepting.
Thank you, ma'am.
Really beautiful cases, beautiful 3Ds. Always it is a pleasure to learn from you. Thanks a lot.
Thank you so much, ma'am. Thank you, ma'am.
Moving on to session number 2, the cervix through colposcope, for which we have our eminent speaker, Dr. Rimpi Singla ma'am, and I would like to invite the chairpersons for the second talk. Firstly, I would like to invite Dr. V. Ramarao sir. He is president of Srikakulam Obstetrics and Gynac Society. Next, I would like to invite Dr. Sarita Upneja ma'am. Ma'am is MBBS from SP Medical College, Bikaner, Obgyn from SP Medical College, Bikaner, ex-Punjab Civil Medical Service owner of Shakuntala Nursing Home, Srinagar, from past 30 years, now president of Foxy, Srinagar. Very warm welcome, ma'am.
It's not Srinagar, it's Sri Ganganagar,
Sri Ganganagar.
Rajasthan.
Sorry. Sri Ganganagar. Sorry. Then next, I would like to invite our very own Dr. Shalini Jain ma'am. Ma'am is MD, FICOG, FMAS, CIMP, ACLS, Gold Medalist, Director and Consultant, Saubhagya Mother and Child Care Hospital, Shivanand Nagar, Raipur. She has a keen interest in high-risk obstetrics and gynecology since 2003. Very warm welcome, ma'am. I would like you to please introduce our speaker.
So Dr. Shalini has also become the secretary of Raipur Menopause Society. So
She's
over
also,
to you, Dr. Shalini.
yeah, she's also active member of SFM and IFS.
Thank you, Dr. Purvi. Thank you, Asha Didi, for giving this opportunity to be part of this Searchlite 33. And I really feel grateful for this. I want to invite Dr. Rimpi Singla. She is an associate professor of Obs and Gynae in PGI Chandigarh. Her areas of interest are cervical cancer screening and management. She is a ISCCP certified colposcopy trainer. Her other areas of interest are hypertensive disorders of pregnancy, safe abortions and contraception, safe use of antibiotics. She is also convener in antibiotic stewardship committee of Gynae PGI, and her various publications, national and international, more than 40 publications. And I invite you to give your talk on the topic, ma'am.
Thank you so much, Asha ma'am, for considering me for this task. And I'm really, honored to be a part of this platform. Thank you, ma'am. So move on with my topic. I'm going to share my screen.
Dr. Rimpi came to our ISCCP conference, and I was really impressed both by her knowledge and by her being so down to earth. So it's my pleasure to have you here, Dr. Rimpi.
Thank you so much, ma'am. Thank you, ma'am. So after going through viewing the cervix through ultrasound, now is the time to see the cervix through the light of colposcope. So this is actually how it looks like when we see through colposcope. This is really important to understand the basics of colposcopy. So for this, we need to know that it's ectocervix, endocervix. Ectocervix is the outer one. It is lined by stratified squamous epithelium, and endocervical canal is lined by a single layer of columnar epithelium, which is thrown into folds, making the crypts and villi. So basically, it is very important to understand this, the junction of the squamous epithelium and the columnar epithelium. This is the main focus of our colposcopy, because this is where the whole of the pathology, whole of the problems arise. Through these subsequent slides, I'll make you understand why this particular zone is so important for us. So this is squamous, inner part columnar, and this is the junction. So it's a very dynamic junction, because at the time of birth, it is at the level of external os. So what happens during puberty, when there is exposure to estrogen, uterus enlarges, cervix enlarges, and then this columnar epithelium also proliferate, and this is how it everts and it comes out to lie somewhere outside, somewhere away from the, it's just grows outwards and crosses over, and this becomes a new squamo-columnar junction, which is away from the internal os. So it is variably away from the actually external os. So this is what happens when there is, this is the normal physiological process under the influence of estrogens, and even in pregnancy and hormonal contraception use. But what happens is the vaginal pH is acidic. So this columnar epithelium, when it is exposed to the acidic pH of vagina, there are some reserve cells at the base which proliferate and become predominant, and then they subsequently differentiate into squamous cells, initially immature, then mature. Now this explains this very well. This is the columnar epithelium. Under the influence of estrogen, this whole part, this is the columnar epithelium, and under the exposure of estrogen, it grew and it came to lie somewhere here. So this became the original squamo-columnar junction. Under the influence of the acidic pH, this reserve cell proliferation and metaplasia, this gradually got replaced by this squamous epithelium from here till inwards. Now, this was the original squamo-columnar junction, and now when the squamous epithelium is growing over it, and now it has reached somewhere here, now this becomes the new squamo-columnar junction. So this whole area becomes the transmission zone, or TZ, because why it is important, most of the lesions related to cancer, that is pre-invasive and invasive, they all arise from this, and most commonly from the squamo-columnar junction, the new one, because this is the place where the dynamic changes are going on, where the metaplasia is it's the active head of metaplasia. So normal metaplasia, not a problem, normal physiological process, but what happens is, at this point, if there is any exposure to mutagenic agent, then this becomes atypical metaplasia, and this is what leads to all of the problem which lead to cervical cancer. Let me show you how. So basically, what mutagen agent we are talking about, this is the HPV virus. So it has affinity for the basal layer, the basal cells. It goes on to infect the basal cells. Initially, it is in the extra chromosomal location in the episomal form, and it allows the proliferation and normal differentiation of the squamous epithelium like this. This is the normal squamous epithelium, and this is where this virus has come inside, but still it is in the episomal form and it stays outside. The whole epithelium is proliferating. This is also as the cells they rise to the surface, this is also coming out, and this is how the viral in the final layer, they are encapsulated by this capsule proteins, and then this is shed off, which we pick up on screening. What happens is, this is fine, but when it integrates into the nucleus of this epithelium, then what happens once it integrates, it's E6 and E7, they are expressed, which takes over the machinery, and this leads to the high-grade lesion and invasive. So basically, the role of colposcopy is here. So why don't we do colposcopy for all the women to pick up all these lesions? That's not possible. It's still a diagnostic test. What the purpose of colposcopy is to pick up the high-grade, the CIN2 plus lesion. That is the basic aim of colposcopy. So having said this, there are certain indications for which we do colposcopy as defined by ASCCP 2019. Based upon your screening test, which is largely HPV based, we have to classify whether the woman has got immediate risk of CIN3 plus or not. If there is no risk of CIN3 plus immediately, then you can schedule her for follow-up depending upon her risk, maybe at 1 year, 3 year, or 5 year. If at present she has got more than 4% risk of harboring a CIN3 plus lesion, then either you recommend her colposcopy, or if the risk is too high, you can even refer her for immediate treatment. So these are the basic the classes under which the ASCCP recommends immediate colposcopy or even immediate treatment. To summarize, if there is a high-grade lesion of ascus H and AGC high-grade lesion, or in case the woman is HPV positive, but she has ascus or LCIL, then she qualifies for colposcopy. But if the woman is positive for HPV, doesn't have any abnormality on pap smear, you are going to review her after 1 year. If she has again shows HPV positivity, that means she has persistent HPV infection. Now she qualifies for colposcopy according to ASCCP. But our WHO is more conservative on this, whereby the indication of colposcopy is any HPV DNA positive test. She qualifies for colposcopy if you are following the screen, triage, and treat policy. And even if you are triaging a HPV positive women by cytology, then also if the lesion is ascus or worse, you are subjecting her to colposcopy. So these are the basic indications where we perform colposcopy according to the two major guiding authorities. So requirements, the basic requirements, we all know that there are a set of instruments which are available. And out of all these instruments, I want to really highlight here about this particular acetic acid. Now, acetic acid, it has to be 3 or 5%. But important thing is that it has to be freshly prepared and consumed on the same day. And most important, you have to know your lab, because if you by chance, anytime you get a direct glacial acetic acid, you're going to cause severe burns. So you have to be very sure that it is adequately diluted to 3% or 5%. It is very easily done, but you have to be very sure of it. Having said this, now we move on to the actual colposcopic procedure. So insert the speculum, adjust your colposcope, and these are, when you insert the colposcope, the magnification it allows is 4 times to 15 times. When you're doing a diagnostic thing, you are looking at the lesions, it is gradually you move on to the higher magnification. But if you have to do a colposcopic directed procedure, in that case, you have to keep the magnification at a lower level because you want to see the cervix in entirety. So the initial assessment is important. First of all, you have to see that whether it is adequate or inadequate. This is very different from satisfactory or unsatisfactory. These terms are no longer existent. We don't talk about satisfactory or unsatisfactory colposcopy. Adequate or inadequate means whether you are able to see your cervix in the entirety. Whether it's not obscured by anything, then it means it is adequate. And after that, you assess for the squamocolumnar junction, which is our main area of interest. And based upon that, you classify it into 3 transmission zones. Now, this is how it looks like. Basically, initially, you have to need to clean with the normal saline for all the mucus and all, and identify the external os, internal, and then external os and the squamocolumnar junction, and look at the vasculature. Maybe you need a green filter for a better appreciation. So when I say adequate or inadequate, it means it is not obscured by blood or the scars or the tears and all. So having done that, then we have to define our squamocolumnar junction. And this is the inner squamous, the newer squamocolumnar junction. And next, it is important to identify the outer, the original squamocolumnar junction. Now, as the metaplasia proceeds, so this gradually immature metaplasia is replaced by the mature one. So it is sometimes, it is mostly difficult to decipher between the, to find out the original squamocolumnar junction. So how do we know? So what was the original squamocolumnar junction? It was actually till where the columnar epithelium originally lied, right? So somewhere here, we don't know. But once you have the metaplasia, what happens is, still you may have Nabothian follicles. You have some areas that I request it's possible to mute down. There are some areas which are yet not covered by the metaplastic squamous epithelium. These are skip areas, or you may even see the crypt openings like in this one. So these, the outermost limit of these things will guide you that probably here it was the original squamocolumnar junction. Why we are interested? Because we know we want to know the extent of transmission zone, because any lesion which is lying outside this transmission zone is unlikely to be malignant or pre-malignant. So this is the importance of it. And based upon the entirety of the new or internal, the squamocolumnar junction, we can classify it into transmission zone 1 or 2 or 3. So 1 means the entire squamocolumnar junction is visible. So we are very certain of our colposcopy. We are very sure that we are not missing out. This is the best of it. And in case only part of it is visible, like in this picture, and the part of it is not visualized, but you may be able to manipulate with a swab stick or endospeculum, and you are able to visualize this is transmission zone type 2. And mostly in the postmenopausal women, what happens is the squamocolumnar junction recedes inside. This is a type 3 transmission zone. This is particularly important when you are planning a treatment, because unless you are sure of your transmission zone, you cannot go for an ablative treatment. So there are some few features of normal transmission zone. The squamous metaplasia, these Nabothian follicles, these skip areas, and the crypt openings, as I already said. Now, the important thing that we are going to apply acetic acid now, which will define our the important lesions, and it also makes the squamocolumnar junction stand out because metaplasia remains slightly whiter than the normal squamous epithelium. What happens when we apply acetic acid? It induces the intracellular dehydration, causes the clumping of the proteins, which is reversible, and it also dissolves the mucus. So it is basically the coagulation of nuclear proteins. The more the nuclear content, more nuclear proteins, the more of the coagulation is there, more of the opacity is there. So it doesn't allow the direct light of colposcope to penetrate through. So this is a diagrammatic representation. This is a stroma. Our blood vessels are lying here, which gives us a pink appearance. So when there's very less of nuclear content, the direct light will come and will reach right here and reflect it from here to give it a pink appearance, which is a normal one. In case of squamous metaplasia, the nuclear content is still higher, but this is still allows some amount of light to penetrate through. So this will appear as a milky light or a very faint kind of this ester whitening. And once you apply Uval's iodine, which stains the glycogen, and in this case, there is a lot of cytoplasmic content, a lot of glycogen, it will turn brown. And in case of squamous metaplasia, this will be less content, so it will be slightly lighter. So having said this, this is how the squamous metaplasia looks like, and this is important that this is a line of metaplasia beautifully stained as white because of the acetouptake. Now, once the lesion is a pre-invasive kind of lesion, once the mutagenic activity has happened, the nuclear content increases so much that it doesn't allow the penetration of light. And on colposcopy, these kind of lesions, they appear as bright white lesion, sharply demarcated. So all acetowhite lesions are not, the suspicious one. So if it is actually the high-grade lesion, they are generally more dense. They have very sharp borders, and they are many of times they are raised above the surface, and of course they are within the transmission zone, and they appear very quickly. You don't need to wait for 1 minute for a high-grade lesion to appear. It just takes few seconds to come up, and it stays for more than a minute. what happens in case this acetowhitening happens and it immediately disappears, then mostly these lesions are benign or may not be there at all. For example, in case of ectropion, where there is outgrowth of columnar epithelium, here if you apply acetic acid, so this will be a slightly whitening and it will even fade away even before the lapse of a minute. And once you have an aceto-white area, it's important to describe the density, margin, location, the size, and how many quadrants does it involve, because this will assign a sweet score, which will guide you the further management. So in this sweet score, if the aceto uptake is thin, it's low grade, it's score 1, and if it's high grade and it is distinct, thick, pearly white, it is grade 2. Margins, if they are irregular, sharp, then this 1, and it's straight margins, it's grade 2. So more the number of quadrants, larger the size, the higher the grade. So this is when on application of Lugol's iodine, if the nuclear content is high and the cytoplasmic content is low, it is going to stain lighter. Like in this case, this is a normal squamous epithelium, which is totally brown. And in this case, it is a patchy yellow, so assign the score of 1. In this case, there is a pale Lugol's iodine, this staining. So this will assign a score of 2. And this is now coming to the vasculature. These are the normal blood vessels, as we used to draw in our drawing files, that a tree kind of thing with a regular fine branching at a tapering dimension. So this is a normal vasculature, how it looks like. But in case of squamous metaplasia or low-grade lesion, what happens? The stromal capillaries, they are projecting vertically upwards, and over it, a thin squamous epithelium, they are visible through it as fine dots, which we call as fine punctations. And sometimes the blood vessels in the stroma, they form a small, irregular network kind of thing of a uniform caliber vessels. So these form a fine mosaic. So these are seen as these are features of low-grade lesions and mostly seen in case of metaplasia. But once, if these vessels, they are neoangiogenesis, their vessels are prominent, they are large caliber, and they are separated by islands of thickened aceto-whitening. So this becomes a coarse mosaic pattern, which is very highly suggestive of a high-grade lesion. So this is again a representation. If you go through a biopsy over this lesion, this is how it looks like. An island of a hyperchromatic nucleus containing cells surrounded by the prominent large blood vessels. And once you do the colposcopy, identify the lesion, location, size, assign it into a low grade, a minor grade or major grade, which is depending upon the morphological features, as I just elaborated. Now in the final few slides, I'll take you through the pictures of these kind of lesions. Now, this is a very thin, almost translucent, with diffuse borders. So this will be qualifying for a score of 0 in terms of the transparency, the aceto uptake. It will be scoring 0 in the terms of borders also. Maybe you can assign 1, but it is diffuse borders and they are very thin area. And in this case, again, it is a milky white with irregular geographical borders. So this acquires a score of 1. Now this is a pearly white, sharp edges, raised above the margin, involving 2 quadrants, somewhere around, say, 10, 11 millimeters. So this is all the scores are going towards 2, including the iodine staining. Now this one also a low-grade lesion, and this one a high-grade. Especially look at the blood vessels over here. They are hairpin bends and all these are also ominous signs. Again, this is a coarse mosaic pattern. And one more important thing, once we see the small crypt opening, this is a normal thing, as I highlighted in the initial slide. But when this crypt opening is surrounded by a thickened, raised aceto-white area, and it is lying within an aceto-white area, this is a very high grade. This is a suggestive of a high-grade lesion. For example, in this case, this is the aceto-white lesion. In this crypt opening is surrounded by a raised kind of, it's just like a donut kind of thing. It's a raised white margin. So these are suggestive of a high-grade lesion. Now the next, the last few things, the inner border sign, ridge signs, these have been recently added. Inner border sign means that there is some lesion occur low grade, and later on at the head of metaplasia, a higher grade lesion appeared. So this is like one border, and this is like another border within a border, the inner border sign. Ridge is again a hypertrophic, irregularly raised, just like mountain ridges. So these are pathognomonic of a high grade lesion. Once these are present, they are highly predictive of this high grade lesion. But in case they are absent, so it doesn't rule out a high grade lesion. So they have got a very, they don't have a negative predictive value. Again, this is a grade 2 lesion with the inner border sign. A ridge. This picture is showing a ridge sign with the elevated, thickened estovite area. Now there are few miscellaneous findings which should not make you be concerned about. These are few acetoid appearing areas which are actually not neoplasia. This is the congenital transformation zone. Now, interesting part about this is during embryological development, the columnar epithelium of vagina is replaced by the squamous epithelium, which starts from the lateral borders, and later on it takes on the anterior and posterior border. So if something is there to halt this metaplasia, which is in utero, what happens? This small patch of this epithelium is not replaced by the squamous epithelium. So when you look at under colposcope, it looks like a acetoid area. But this typically starts from the anterior lip, goes on till the vagina. These are they do not carry the malignant potential. Leukoplakia, condyloma, they all appear as white, but mostly they are maybe out. This particular like lesion is like outside the transmission zone. Apart from that, you have to not restricted yourself to colposcopy to picking up the high grade or low grade lesions only. You may see the vaginal infections, polyp, which gives you an opportunity for treating them also. Now, last part, the documentation. There is the SWEET score. You have to document the provisional diagnosis and make a diagrammatic representation and write down a provisional plan. So this is how you divide the coordinate. This is how you localize the lesion by the dial position. And this is how you calculate the SWEET score and assign just formulate a plan accordingly. And this I have took out from IARC. This is the colposcopy documentation form, which demands a SWEET score and a management plan and a follow-up appointment. So I recommend that all those who are doing the colposcopy should have a documentation form, should have a consent form, should have a proper dedicated person who knows how to counsel these women. And because of the time limit, I've skipped upon that part, that counseling is very important before you proceed for a colposcopic examination, because once the patient is picked up of having a abnormality on pap smear, she treats that it is synonymous with cancer. We have come across the patients in whom this was a HCl on pap smear, and subsequently she had the cervical biopsy, she had a high-grade lesion, and then we were planning her for conization. She disappeared and underwent hysterectomy, and ultimately she was diagnosed to have invasive cancer. So this counseling part is very important so that the patient doesn't get lost to follow-up or land up in a wrong treatment. So this is all, this colposcopy, this diagnosis, this screening, this is a very important part of our screening strategy, which we hope to eliminate cervical cancer if we approach the 70% target in screening. Thank you. Thank you, everyone. Especially thank you, Asha ma'am.
It was a great talk, ma'am. Thank you so much. I would like the chairpersons to ask if there are any questions and address the talk, please.
Dr. MP, I've been listening to colposcopy for 30 years. I never heard such a concise and well-pictured lecture. You know, Gagar mein Sagar, you really put it all together. So that was very good. We have one comment on YouTube where it is being said that never go for an ultrasound before first doing a PSPV. Do a PSPV and then go for an ultrasound. Dr. Kishore Rajurkar has made that comment. Yes, ma'am. Would you like to say something? Dr. M. Sai, would you like to say something?
It was a great talk, ma'am. I never see the pictures. They are very well done.
Thank you, ma'am.
Shalini, would you conclude?
Said, ma'am, as you said, in fact, I never heard this concised presentation since how the transformation zones develops and how to interpret and how it works in other pathologies too, apart from malignant and benign lesions. So really hats off to you, ma'am. Rimpi ma'am, you have done your job in 10 minutes. That is really commendable. Thank you so much. And it was a delight and pleasure to, listen this talk. Thank you, ma'am.
Thank you so much, ma'am.
Giri sir, if you are there, if you would like to say a few words. Dr. Pushpavati has joined from the delegate link. I've asked her to join from the faculty link. So I'll call once more. And meanwhile, you can start introducing the chairpersons.
Yes, ma'am. For our third session, which is on cervix through microcolpohysteroscopy, we have Dr. Pushpavati ma'am as our main speaker. And for chairing the session, we have firstly Dr. Uday M. Patel sir. He is Professor HOD Obs
अरे
Gynae
शुरू हो गया, तुम्हारा इंट्रोडक्शन चल रहा है.
Professor HOD Obs Gynae Department in Medical College, Dharpur, Patan, North Gujarat. President, Patan Obstetrics and Gynecological Society.
तुम्हारा इंट्रोडक्शन हो रहा है.
Secondly, I would like to welcome Dr. Sushma Nigam ma'am. Ma'am is gynecologist at government service in various hospitals. She has successfully completed over 10,000 plus laparoscopic tubectomy, 30,000 plus LSCS, vast expertise in obstetrics and gynecology. She has active involvement in medical research and continuing education. She has proven leadership skills in managing healthcare teams, extensive experience in managing complex gynecological conditions, active involvement in community outreach program. She has done her MBBS from Raipur Medical College and her MD Gynecology from Gandhi Medical College, Bhopal. Thirdly, I would like to welcome Dr. Premlata ma'am. Ma'am is a president of Nizamabad Obstetrics and Gynac Society. She has special interest in high-risk pregnancies, infertility, adolescent health. She has a work experience of over 28 years. She's director at Kirti Sai Multi-Speciality Hospital, Nizamabad. Very warm welcome, ma'am. I would like you to please introduce our speaker, Dr. Pushpavati madam.
तू कहाँ है? नहीं, पर तू डेलीगेट लिंक से ज्वाइन की क्या?
Ma'am, you're muted.
Please go ahead and introduce Dr. Pushpavati.
Dr.
They've all joined from delegate link.
Oh,
They are unable to join from faculty. I'm just coordinating that.
okay. I would like to introduce our speaker for the third session, Dr. Pushpavati ma'am. Ma'am is MBBS, MS Obs Gynae, FICOG Professor of Obstetrics and Gynecology in AIMS Raipur. She is trained in gynec oncology, colposcopy in gynec oncosurgery and laparoscopic surgery, trained in medical genetics and also master clinical trainer for safe abortion practices and alternative IUD techniques. She has presented papers in various national and international conferences and received Best Poster Award for presentation in National Fertility Conference 2013, New Delhi, India, and Gold Medal for presentation in National Infertility Conference 2014, Pune. Publication in national and international journals, completed intramural and extramural research project, National Coordinator of Birth Defect Surveillance Program, ISCCP certified colposcopy trainer, and her area of interest is gynec oncology, MIS, and high-risk pregnancy. We'll just take a few minutes for her to join.
if it's taking time, do you think we go ahead with the panel first?
We can, ma'am. If the panelists, yes, ma'am, I think we can do that.
How many panelists are here? They would join later otherwise. Sushma has joined. Pushpa has also joined.
Okay.
So I would stop sharing.
Yes.
Welcome, Dr. Pushpavati ma'am. You may share your screen.
Yes, ma'am, I'm sharing my screen. Hello.
Yes, ma'am. We can hear you.
Yeah. Hello. Good evening, Dr. Purvi.
Good evening, ma'am.
My slides are visible. Actually, I'm joining through the mobile app only.
No, ma'am. we
Your
cannot
slides are
use-
not visible.
Okay.
Pushpa, can you WhatsApp me the slides?
Okay, I'm going to WhatsApp you, ma'am, right now.
Yeah, so I will play the slides.
Okay, no issues.
Pushpa, done?
Yes, ma'am, I've sent you.
आया नहीं.
अभी आ गया, ma'am. 1 click, 2 click. Yes.
किस नंबर पे भेजा है?
Hmm. 94252.
आया नहीं उस पे अभी तक. अच्छा, विनीता के नंबर से भेजा है.
No, it's not Dr. Vinita. It's my number.
ओके. डाउनलोड हो रहा है. I'll do it.
Okay,
Just a
ma'am.
second.
काम करती हूँ वहां से मैं प्रेजेंट कर देती हूँ.
Hello. Can you see me and hear me?
Yes, ma'am.
Yeah, please go ahead.
Okay. Thank you. Ma'am, am I audible clearly? Hello?
Yes, ma'am, you're
Yes, you
audible.
are audible.
Okay. Thank you, madam, for inviting me and speaking on our topic, microcolpohistoscopy. We already started with a very nice class that including the cervix through the eyes of the ultrasonography. Then second, we go through the colposcope. Now we are knowing the endoscopy in all the part of all the women's surgery, gynecological surgery, and all kind of the surgery. The endoscopy is entered. So why the cervix? Cervix is the only organ in which we are not talking about the endoscopy. But now, when it comes to the microcolpohistoscopy, again, this endoscope plays a very, very important role. And this endoscope is available, I think, in majority of the individuals, or this is just a 2.59, 2.9 mm scope, which is available, and it provides a very good view so that we can decide what exactly the patient itself is having on her cervix. So now I'll come to the part, and this part is exactly what's supposed to be the microcolpohistoscopy. So when it comes to saying this is one of the method of contact microscopic examination of ecto and endocervical epithelium after in vivo staining. So what exactly we do in this microcolposcopy? We stain the cervix and then we directly examine. The way we are seeing the slides after making the slide preparation, and we are seeing under the microscope, the same thing the person can see while the person is doing the microcolpohistoscopy. So when it comes to the microcolpohistoscopy, what help this microcolposcopy is giving to the gynecologist, it directly examine and observe the cell lining of the vagina and the uterine cervix that everyone know, because nowadays the vaginoscopic approach is the main approach for the examination before doing the histoscopy. So we are doing the histoscopy, we enter through the vaginoscopic approach, and we are seeing how the cervix looks beautiful and how the vagina looks. So after examining the cervix and vagina, then we enter in the cavity. So this is the one technique that everyone will follow. So why not to enlarge our own scope through the eye of the microcolpohistoscopy. So this microcolpohistoscopy, in addition to this tender histoscopy, it allows the cellular observation in vivo, and it provides the immediate diagnosis of the gravity, its location, and the extent of any lesion. So microcolpohistoscopy provide the contact vision of the epithelium up to 150 magnification. And what are the things basically these are which are required for the microcolpohistoscopy? A contact histoscope with the light source, fiber optic cable, and a camera, obviously to attain an adequate view of the cellular element on a monitor. So one monitor is also required. And you can see clearly in the picture, this picture is showing the contact histoscope, and this contact histoscope in the picture itself, this is having a knob, and this knob is basically for the focus, and light cable you have to attach it, and along with that it should be attached with the endoscopic camera and monitor, and the view can be visualized directly on the screen. And the diameter of this sheath is 2.9 mm. Then it comes to what are the things which are required. One is the contact histoscope. Another, we need two things. The way we are requiring two or three things in cases for the staining the cervix, two things are required for the this colposcopy. The similar way, we need the two things. One is the normal saline to clean the cervix. After that, we have to apply the lugolzadin, and then a simple fountain pen dye, which is a waterman's ink, can be applied, and the cell can be examined directly. And after direct examination, we can see the alteration in the cellular pattern, and this pattern can tell us about whether the cell is normal or it is having the features of the infection at the cellular level. And then we can see the lesions, whether the high grade or not. So these are the things which can pick up. So the simple things which are required is the contact histoscope along with its fiber optic cable, video camera, and the monitor, and then lugolzadin and this dye. Then techniques. When it comes to how we supposed to do the microcolpohysteroscopy, it's a simple technique. We are doing a colposcope, we are knowing, and here the only thing which change is actually the scope. So what are the steps? So the similar way we are doing the colposcopy, we have to take the consent, we have to explain the procedure, we have to do the proper documentation, and after that we have to, the number one step is expose the cervical epithelium, cervix. After exposure of the cervix with the help of the speculum, the cervix is cleaned with the normal saline to clean the cervical mucus and to see the cervix clearly. And after cleaning, you have to see examine the cervix, whether cervix is having any lesions or not. And then you stain with the Lugol's iodine solution. And what the same principle will work with the Lugol's iodine. The mature cell take a uptake. Columnar cell will not going to take a uptake. After the application of the Lugol's iodine, we can see the stain in the non-stain area clearly. And after that, in the step 3, what we supposed to do? We supposed to do the application of the Waterman's ink. Waterman's ink. This Waterman ink. What is the role of this Waterman ink? So these are I'm sharing the two pictures. One picture is a normal cervix. Another picture is the cervix which shows after staining of iodine. Okay. Then in the step 3, what we supposed to do in a step 3, we have to apply this Waterman's ink or the fountain pen ink. And after this application of the Waterman's ink, what happened? It actually penetrate into the cytoplasm and the nucleus of the mature squamous epithelium and into one inner squamous metaplasia, which are less mature, and leaving the columnar epithelium colorless. Now, after the application, we'll see how the cells are visualized. This feature allows an easy differentiation between the squamous and because columnar is not taking uptake, squamous is taking the uptake, which are mature one. And is easy to make the difference between the squamo-columnar junction and identify the lesions which are pre-neoplastic, and pre-neoplastic, and we can easily identify two things: whether the cervical tissues are normal, or it is infected with HPV, or it is showing the high-grade lesion. So now it comes to the interpretation, how we interpret those results. When it comes to the interpretation, here I am sharing you the one slide, and this slide is showing 3 different areas. So this you can see beautifully with the contact hysteroscope, which can give the magnification of approximately around 150 times magnification. And on the left, you are seeing columnar cells which are unstained. On the right, you are seeing cells with a small nuclei and clear cytoplasm, and this is suggestive of the superficial squamous epithelium. And in between that, you are seeing the cell which are stained with a dark blue color. So this blue color cells are actually the cells from the squamo-columnar junction. Now, how are we supposed to check the changes? How the normal epithelium looks? This normal epitheliums are basically, they looks directly on a contact microhysteroscopy. These are the pycnotic cells with the pycnotic nucleus regularly distributed on the surface of the epithelium. And this can tell us the findings are normal. When we are seeing the HPV infected cells, how they appear. We all know the perinuclear halo. Everyone knows. The same thing you can visualize in a contact microhysteroscopy when the cells are surrounded by the clear perinuclear halo and nucleus is hyperchromatic. If that you see, your diagnosis is towards the HPV infected tissue. Then how the abnormal cell looks. So the high-grade lesions look on a microcolpohysteroscopy. You can clearly see the cells with the larger nuclei. There is a change in ANC ratio, irregular cell wall distribution, and these changes are suggestive of the lesions which is high grade. And if we are observing this kind of the lesion, means the area is affected. So these 3 pictures are clearly saying the picture number 1, which is the normal cells, Second is HPV infected. And third one is suggestive of the high-grade lesion. So these are the three pictures which tell us how this microcolposcopy is going to help you by simple staining with the two dyes, that is a leucozyadine, and second is the waterman's ink, or I can say the fountain pen ink, which is freely available. If you will search on Amazon, you can easily identify those dyes which are available. Then it comes to the what are the advantages we will get with the microcolpohysteroscopy. We are doing a HPV testing. We are knowing whether our patient is positive, high risk positive or not. So these are the two things that we will get: infection. Secondly, whether our patient is a case of high. But with the help of this, we can identify the cellular alteration and the degree of the cellular alteration. Then when it compares to the cytology will not tell you the position and the extent of the altered cell. But yes, when it comes to the microcolpohysteroscopy, you can easily see where it is located, what are the extent, and it eliminates the interval between the sampling and the. So after taking the cytological testing, we wait for the result. But in these cases, you can do the treatment directly to the patient after seeing the lesions, how it looks, whether it's infected lesions or your patient is a case of high-grade lesion. Then when it comes to the colposcopy, yes, colposcopy, there is no replacement for the colposcopy. But what happened in the cases of the colposcopy? Sometimes we are facing a problem when we are not seeing the squamous columnization clearly. In those cases, in which the SCJ is received back inside, in those cases, or a type 2 or type 3 transfusion zone, yes, this microcolposcopy is going to give great help for identifying the lesions by seeing it directly. And it is not only microcolposcopy, not only helpful it's also helping along with the colposcopy. We can do it and not only identify the location of the lesion, we can also diagnose this HPV infection simultaneously. Then this microcolpohysteroscopy, we can do it prior to the cone biopsy or leaf excision. And once the leaf is excised or the conization specimen is excised, you can again restain the area. You can see whether you have completely removed the lesion or not. So that is the beauty of the microcolposcopy, that you can see the lesion directly and excise it. Even after excision, you can see the completeness of your procedure, whether you have done or not. So these are the basic advantage that we will get with the microcolpohysteroscopy over the colposcopic examination or the evaluation. So next is my references. For the references, the study, as I told you, the study is not a new study. The studies are done in 90s and 95, and on 80 is the contact hysteroscope is already introduced. And with the help of that contact hysteroscope, with the one knob in that and fiber optic everyone is having, we can do it microcolpohysteroscopy. And the larger series, which is published by the Lugi, who is actually the person who is advertising a lot about the microcolpohysteroscopy, we supposed to include this in our thing, because we are doing a lot of endoscopy, and all the area of the female genital tract, we are entering through the this endoscope. So why not this area? So just either you do it this alone, or you can do it with the colposcope and complete the things and directly examine the cervix. So this is all about my presentation. And this is a short presentation because whatever the thing which are available, I just compile it and present it in front of you. Thank you.
Thank you so much. Thank you. Giri sir.
Thank you, ma'am.
Giri sir. And Dr. Rimpi, if you would say something, please. Dr. Rimpi.
Yes, ma'am.
Yeah. Your comments.
It was really very nice presentation. I have one question that you said it's a contact microcolpohysterography. So, I mean, the normal hysteroscope that we use is not the right thing, right?
Madam, no. The magnification, if you'll see, ma'am, am I audible?
Yeah. It is 150
actually
times.
we are doing, and we tried with both. But when we start using the contact hysteroscopy, we are identifying the lesions better because the magnification is very high. You can clearly see the vessels, cells, even this cytoplasm. You can see it clearly. So with the normal hysteroscope, this endoscope, it is not possible hysteroscopy that we are using. But yes, when it comes to the contact, it actually gives the magnified view so that we can see the cells.
Thank you.
It's a different hysteroscope.
Yes, ma'am. It's a contact hysteroscope. Like I showed you in the picture, it is the 2.9 mm dia, and we can the camera that we are using for the hysteroscope, we can attach it. It's with the storage also, it's with the wolf also. So everyone has those who are keeping the hysteroscope, they are providing this. If you will say we want the sheath of the contact hysteroscope, they will give it to you.
Okay. Now something has happened that I'm unable to share. So somehow the share is not working. It's not working at all. So,
Ma'am,
let
maybe
me
you can
see.
send it to somebody and then.
You can send it to me, ma'am.
Actually, what is happening is the presentation of the panel is already in the group. Okay.
Yes.
And I will send you the presentation of the CV deck.
Yes, ma'am.
Okay.
Yes, ma'am.
Today something has gone wrong. I don't know what. My Zoom crashed in between and then it's not allowing me to share. Thankfully, it allowed me to share Pushpa's presentation.
Thank you, ma'am. Thank you very much, because we are in the hospital right now and we came for the emergency. So that is why I'm presenting to you.
Okay. Purvi, will you try?
Yes, ma'am.
Sarita has joined. You know, most of my panelists I cannot see. So anyone who's present here is welcome. It's not allowing me to share at all. Yes, she's sharing.
Is
She's
it seen,
sharing
ma'am?
at present. Yeah, it's seen. You have to go stay here. Yeah. So I've been introduced already. Next, please.
Okay.
So we have very expert panelists, Dr. Supriya Gupta, who's a gynec oncologist, assistant professor at Pandit Jain Medical College and DR Ambedkar Hospital, Raipur. Next, Dr. Mithilesh Garg, ma'am, is the president of Alwar Society. She has not been able to join. Dr. Mrinalini Zalak, president Baramati, just had an emergency. Next, Dr. Bharat Pawar, sir, is consultant obstetrician gynecologist, sonologist, and infertility specialist at Akluj. So he's also the president of Akluj Society. Dr. Gaurav Gadvi, the president of Nadiad Society. We have Dr. Nishi Garg, who's the president of Kotkapura Society. We have Dr. Sarita Rajbhar, who is the associate professor, Department of Obstetrics and Gynae, Raipur. And we have Dr. Meenakshi Rohilla, who's the secretary of Northern India Obstetric Gynae Society. So, D2.
Ma'am, are we sure that the panelists have not joined through the delegate link or something?
Means there's no way of me knowing.
I joined by delegate link.
Can you see my screen, ma'am?
Yes.
Is this okay? Should I proceed?
पहले गणेश जी को ले आओ, फिर शुरू करते हैं.
Yes.
Purvi sharing, I cannot share. So, with pranams to Vignaharta, we start the panel. And next, please. Next. Next, go to the questions directly.
Okay.
So we have the initial introductory questions. How does the cervix develop embryologically? How does it develop? Requesting everyone to put your videos on. Supriya, Dr. Sarita.
Good evening, ma'am.
Yeah, who's speaking?
Ma'am, I'm Dr. Sarita Rajpal.
Yeah. So just a couple of sentences about the embryology.
Regarding the embryology, cervix basically develops as part of the other Mullerian structures like uterus, cervix, fallopian tubes. They all develop from the Mullerian duct.
Okay. So how does embryology impact anomalies?
Like there are many reported Mullerian anomalies, but ma'am, you are asking regarding how they affect cervical cancer with respect to cervical.
We are not talking of cancer. Any clinical, any clinical, any abnormality, the Mullerian, how does it impact clinically?
Yes,
does it have any clinical implication?
The Mullerian abnormalities basically affect the if it is cervical agenesis or high vaginal septum. So they will be usually presenting with cases of primary amenorrhea, and patient will be having severe dysmenorrhea, cyclical pain.
Okay.
While in future, reproductive later on, they may present with fertility aspects. Like if they're not corrected adequately in the correct center, in an appropriate center, then they may develop future endometriosis or like Mullerian MRKH abnormality if the patient is having, then she may be having fertility issues. So she have to conceive via surrogacy. So these are the basically fertility and pregnancy aspects are there regarding Mullerian abnormalities.
There can be non-canalization of the cervix if there is no dissolution of the septum, or there can be two cervix uteri.
Yeah, that we saw today.
Yeah.
Sepsis and bicordate will be resulting into recurrent pregnancy losses.
So in the first trimester itself, somewhere around 8-9 weeks, what happens? The the ducts it develops in relation to mesonephros. There are two ducts which are coming together and they are supposed to fuse. And the uppermost cranial part, which is not fused, remains as the fallopian tubes. And if there is any problem with the fusion, which is the main thing, so this leads to the various anomalies ranging from arcuate uterus to subseptate to septate to complete diadelphys, or the upper third of the vagina is also coming from this, in connection with the uterus and cervix. So there actually the septum and all, most of the time we see this in a higher level. So that is it. These are the things which the fusion, there is a problem. Or in case one side the system doesn't develop at all, then we'll have a unicornate thing. So it is particularly important to look at the kidneys also in these kind of patients. That's it.
Thank you. So, what are the age-related changes that we see? पूर्वी ज्यादा ऊपर हो गया, नीचे.
Age-related changes are like when the girl attains menarche or means she's in early reproductive age group, then not menarche, because we do not screen these age group, but when they are in early reproductive age group, then we may be having like ectropion, increased incidence of ectropion related issues. While just at the extreme of the age group, like when they attain menopause, then we may not be able to visualize the transformation zone at all, like ma'am had described previously. So this leads to difficulty in identification of the lesions because they are largely endocervical and we need manipulations or conization, etc. They cannot be detected on colposcopy only.
That is what happens in menopause, right?
Yes, ma'am.
So next slide. Most common pathology, what do you see? If you are seeing 100 patients, then what is the most common thing in the cervix that you're going to see? And would you even call it pathology?
Cervical erosions,
Ma'am, that is the biggest thing that we want to bring up today, that there is no such thing as erosion. It is basically an ectropion. It's ectopy of the columnar epithelium, and it is a physiological thing. It's not pathology at all, but it is labeled erosion, bad cervix, and the patient is offered treatment for something that is normal and cannot be treated. So we all know that HPV impacts cervical health, but what is the frequency of that HPV infection?
5% somewhere. 5-7%.
That is persistent HPV infection.
It depends upon
5 to 7% will have persistent infection, but how many actually get infected?
Quite high.
A younger age,
80%.
The incidence
it's 80%.
80%. Yes, ma'am. That is what I.
Yeah. So we don't test before 30 years, and that the reason is that before that maximum will be positive only, and it will just give stress. So the cutout for testing HPV is
30 years.
30 years of age. 30 years of age. Next slide. If it is a reproductive age girl, what is the problem in examining the patient? If she is perimenopausal, then what? And if she is postmenopausal, what? Nishi ma'am, this I want you to answer. So what problem do you feel in examining a patient?
The patient will not allow the speculum examination in many cases.
No, ma'am. In different ages. If she's a young woman, if she is perimenopausal, if she is postmenopausal, what happens?
If she is a young patient, this vaginal speculum examination becomes a little difficult. So, and in reproductive age,
in our country, we are talking only of those who are sexually active. Okay. So,
one is
in the perimenopausal age group,
some people are not willing for the per speculum examination. Many of the patients, they will not give consent for per speculum examination, because when we take the patient on the table, after seeing the speculum, sometimes they say, no, we don't want this pelvic examination. So I think that is a little.
So Dr. Rimpi missed out on the counseling. So I think that counseling that she said was important and there was no time. You need to counsel. You cannot examine a patient and not do her PS examination, right? So we have to counsel and do it. The problem is that you might not be able to look at the cervix. A woman who is perimenopausal or who has not had sex for a long time, she's had 2 cesareans, 3 cesareans, cervix is pulled very high. If it's very high, you can't see it. If she's perimenopausal, she's postmenopausal, the cervix is now atrophic, and an atrophic cervix has a very different presentation. Because it's an atrophic cervix, the squamocolumnar junction, the transformation zone, as Dr. Rimpi has just shown, will not be visible at all. And therefore, it is an incomplete examination. You need to look at other things. Okay. So, the anatomical variation and patient discomfort, does it impact the accuracy of examining the patient, the cervix? I just gave you the answer.
Yes, there is the problem, because if it is a very much retroverted, anteverted uterus, then sometimes cervix is pushed up so back that it's difficult to see with the cuscous speculum. So sometimes we have to use same speculum for that. That is.
So basically the position of the uterus, the adhesions that it might have, and then the postmenopausal status, they would all differ. Next, please. Now we come to the first case. Everybody here is requested to pitch in, everyone who's here. A 35-year-old presents with intermenstrual bleeding for the past 3 months. Previously, she had normal cycles. Now she has come ki only for the last 3 months, she's having intermenstrual spotting. Now, what could be the cause? The physiological cause and the pathological cause.
Physiological, we can say that there can be this ovulation bleeding. Sometimes it presents with the spotting, and there can be some polyp. There can be some polyp lying there, or thickened. Anything can be there. Then thickened endometrium can present with bleeding, or there can be just vaginitis, which is presenting as in between spotting during the menstrual cycle.
Okay, what do you think about polyps? Will polyps cause intermenstrual bleeding?
They can cause.
Yeah, because postcoital bleeding can be caused by polyps. Right? Now, if there is cervical ectopy and cervical carcinoma, how would you differentiate? You see a polyp. So whether it is just a polyp or it is a cancer, how would you differentiate that?
Polyp will be very smooth outline, will be visible on the outer surface and can be.
And Dr. Rimpi just told about acetic acid.
Yes.
So you can apply acetic acid and Lugol-Side and you can evaluate it properly.
It will have all the features of a high-grade lesion, right from the abnormal vasculature to the acetowhitening to the dense acetowhitening, everything it will be showing up.
If it is a cancer, right? So now what are you going to do? What are the tests that you're going to advise this patient? She has just come for intermenstrual bleeding. So what all are you going to do for her? So Priya, अपना video on करो और सामने आओ. What are you going to advise her?
She will need a thorough investigation, like starting from transabdominal ultrasound.
Ma'am, first PS examination.
Speculum, yes. PS, I thought we have done already to see the
Yes,
thing.
ma'am. And, is the diagnosis of polyp done, or we are investigating a bit?
We are investigating
No, we are investigating intermenstrual bleeding. So what are we going to do now?
So per speculum, then transabdominal ultrasound. Again, after counseling, then transvaginal if need be. Seeing for the endometrium, seeing for fibroids.
Ma'am, for evaluation of a uterus, what is a better modality, abdominal or vaginal ultrasound?
Because one abdominal ultrasound, you see whole of the outline of the uterus.
Ma'am, the vaginal, Dr. Raju
Vaginal
just
is
showed
good.
you.
Yes.
Vaginal is the better modality.
Yes.
So you only do abdominal when the uterus is big and it cannot be covered by your probe. Otherwise, a vaginal ultrasound is good enough.
Right.
So,
Especially in the intermenstrual bleeding, we are talking about, in those cases, generally it is the polyp or atypical hyperplasia or carcinoma endometrium. We are talking about the uterine causes. Fibroid typically, unless there is another, there are sarcomatous change or something, they typically have a cyclical menorrhagia. So,
ma'am, but if they have
most of
a
the cases,
fibroid
unless
polyp,
there's a
that
fibroid
also
polyp,
causes
yeah,
bleeding.
that's what. Unless it is a fibroid polyp due to erosion, it can cause intermenstrual, but the other ones, they do not. So the transvaginal scan will help us in this.
Okay. So now, would you want to do a colposcopy here? Or you want to do some other test? You want to do a pap smear or HPV? Or you want to do direct colposcopy?
Ma'am, actually, for while doing the PS per speculum examination simultaneously, first thing, if she has not undergone a PAPS and HPV, we should have taken that. First thing is always that. Then, if in case of examination we are finding a smooth polyp and no other cervical and the visual inspection the transformation zone is visible, there is no point of doing colposcopy in such a case. If she doesn't give the history of postcoital bleeding per se and no chronic
Would
history
you
of
still
prior
apply
discharge.
acetic acid or not?
Sorry, ma'am?
You don't want to do colposcopy, but would you apply acetic acid and see, or would you not
Visual
apply?
inspection of acetic acid can be done in the same setting.
No, I'm not saying can be done. I'm asking you,
It
will
should
you
be
do
done.
it
It
or
should
will
be
you
done.
not?
It
So,
should be done.
then it's your choice whether you want to look at it through the colposcope or you want to
Yes,
see it
yes.
with your naked eye. But you need acetic acid application even if it appears smooth. Okay, now if she has an abnormal pap smear, then when are you going to consider a biopsy? What is the level of pap smear where you want to do a biopsy? Yes, Dr. Rimpi.
All abnormal pap smear, they don't qualify for biopsy straight away unless you have
Exactly.
a lesion. If you have a lesion also visible, you will straight away take a biopsy anyways. But you are doing a pap smear because you are not seeing an outrightly a lesion. So otherwise, from where will you take a biopsy? From a normal looking cervix, this has to be colposcopically directed. And there also, if you have a high grade lesion, then you proceed.
So if it is an ascus, a simple ascus, would you want to do a biopsy when you're not seeing any lesion? No. It's an ascus H and you're still not seeing a lesion. Then would you want to do a biopsy?
Colposcopy, ma'am. H qualifies for immediate colposcopy.
So you have done a colposcopy, you're still not locating the lesion. What will you do?
Ma'am, if in colposcopy and you are having a ASK-H cytology and on colposcopy you don't have a lesion, first thing you do is you talk to your pathologist. Talk to your pathologist to confirm the diagnosis of ASK-H. If the person is very sure that it is ASK-H and you are very sure that you are dealing with a type 1 transformation zone, then the probability of having the cervical pre-invasive lesion is very low. But in case it is a type 2 or a type 3 kind of thing, then actually it qualified for an excision. There's a
Okay, so
discrepancy in
I
the.
heard Dr. Sanger saying that in that case, go ahead and do a 4-quadrant biopsy. Because a 4-quadrant biopsy will be able to get the lesion in 70% cases where you are not able to see it. That was Dr. Albert Sanger. These are his words, which he said repeatedly. So with this, we go to the next case. This is a clear-cut HCL. Okay. So what are the risk factors for HCL? Which patient is more likely to get HCL? I'll give you a hint that cervical cancer is an AIDS-defining disease.
Multiple sexual partners, early marriage, more children, more chances of more vaginal infections. And if we have done HPV, it's positive. So all these, they fall in the
So
category
basically, any condition that leads to low immunity.
Yes.
Immunocompromised.
Any immunocompromised, because 80% get the infection. Out of that, 80% will clear it with their own immunity. Why are some people not clearing it? Because there is some problem with their immune status. They may not even HIV positive, but still there is immunocompromise. So, does 100% HCL progress to cancer? Supriya?
No, ma'am, 100% will not progress to cancer, but there is a high chance that 55 to 70% of the HCL may progress to cancer within the next 24 months. So that 24 months.
How much? How much?
55
what
to 70%. Around
No, that's
35%.
wrong. That's wrong. That's wrong.
Ma'am,
That's
55
wrong.
to. Okay.
That's wrong.
Okay, ma'am.
Okay, 45% of very high grade lesion will revert back to normal. And it is not 2 years. If it is what previously used to be called CIN2, out of that only 10% will progress. Okay. And it is over a period of 5 to 10 years and not 2 years.
Okay, ma'am.
Rimpi ma'am, correct me if I'm wrong.
Ma'am, you are absolutely right. It's quoted in this thing is 12%, 14%, not more than that.
Yeah.
And that also
So,
this time.
Yeah. So how do you manage a case of HCL? I'll ask you, all the gynecologists present here. Shalini, I would like you also to join in. Would you want to do a hysterectomy on this case? She has HCL. She is 35 years old and she 30-year-old. But she has completed her family. You want to do a hysterectomy or you want to do something else? You've done a colpo, the biopsy has proven HCL. Now what do you want to do? How are you going to treat her?
Ma'am, actually for HCL, actually it should be accompanied by HPV testing. First thing. Second thing, if we have done a biopsy, how we will grade it, whether it is CIN2 or 3. And then HCL can be managed by an excisional biopsy. Cone biopsy can be done in this case to rule out any underlying malignancy, which is generally present in 5 to 20% of the cases. So a cone biopsy will be an apt procedure for her. If
your percentages are a little on the plus side, Supriya, you need to be reading about them, because HCL 5 to 20% is not invasive. It's not.
Can hide underlying malignancy, ma'am.
No, so that makes it invasive. It doesn't work. It's that percent is not 20%. Okay, so you would do a cone. You've done a cone now. The margins are also clear. Now, when are you going to follow her up?
Ma'am, I just want to add something here.
Yes,
all
please.
the major recommendations, they are suggesting that LEAP is the treatment of choice. Wherever, it's better to do LEAP. Conization is specifically where you do not do the LEAP is if you have any doubt of microinvasive or it is adenocarcinoma in situ. In those cases, you will not do LEEP. For the rest of the things, if it is accessible, the LEEP is preferable. I mean, this is just in addition to what we are doing. It is excision in any of the forms.
So you've done an excision. The margins are also clear. When are you going to follow her up? And how long are you going to follow her up?
1 year. After 1 year, the next follow-up, unless she has any symptoms before that. And after 1 year, we are preferably going to do a co-test. That's what we do here. So, and the follow-up will continue for at least 20 years till you have a negative margin. In any case, you
That is
have
the most important thing, that she has to have a follow-up for 20 years. Because there is an increased chance of relapse even with negative margins for 20 years. That figure has to be remembered. Okay? Is there some advice that you would give her? Have done her LEEP. Is there some advice that you would give her? As a normal gynecologist, what are you going to advise her?
Ma'am, hygiene, not to douche, not to have intercourse. She will have a discharge which may be slightly blood tinged or brownish. She should not bother. But in case she has a high grade fever or a persistent pelvic pain or heavy bleeding, she should report back.
Yes, and we would like to correct any deficiency she might have, whether it was of hemoglobin, vitamin D, B12, whatever. If she is deficient, because we want to build up her immunity. If her immunity is good, once we've cut away, the healing has to come from itself. Healing will only come with the patient's own. Purvi, next slide, please. Now, this is a 29-year-old with LCIL. She says, I had an HPV infection. Why she got tested at 29, you don't know. But she said, I previously had HPV infection. And now she has a pap smear with LCIL. Rimpi, is going to be just you and me discussing, I think. Nishi ma'am, Dr. Supriya, Dr. Sarita. Come on, we can do it fast. What's the basic difference between LCIL and HCIL? Now that WHO has defined two categories, what is the difference?
Ma'am, it's a cytological test. Basically, under the microscope, we look at the characteristic
No,
features.
that's okay. The interpretation, what is the difference in interpretation?
Ma'am, earlier it used to be classified as CIN 1, 2, and 3 because of the overlap between the 2 and 3. So they were classified into HCIL, and LCIL now it is restricted to CIN 1. So this
Actually,
is the
LCIL is a state of HPV infection.
infection, yeah.
And HCIL is a state where DNA changes have started.
Yes, it's where the HPV has actually integrated into the
Yes.
host
So
genome.
that is the basic difference, that one is LCIL, where it is just an infection and
episomal,
therefore it
yeah.
does not need treatment.
It is
And
in
then
the
you have
episomal
HCIL.
form. This allows the normal maturation of the epithelium to go on, and it is in the episomal form only. It is a low copy number of HPV DNA.
Yeah. So are you going to manage it, or you just want to follow it up?
LCIL lesion per se, for this, I mean,
He's 29.
Ma'am, all the recommendations are like more than 25 years of age in ASCCP. They are classified as less than 25, more than 25 when they talk about treatment. So if this is a cytology result of LCIL, so we can proceed for colposcopy. And especially if she is HPV DNA positive, all the more reason we should proceed for colposcopy. And LCIL lesions, generally, they have low-grade lesions on colposcopy. And in the beginning, I would suggest that you can do the biopsy and be assured, but later on, with experience, you know that these are only metaplastic changes or HPV-related changes, they come up. So actually, you don't need to treat these lesions.
So what is the likelihood of regression versus progression in LSIM?
Ma'am, percentage I don't remember. Definitely very large percentage they regress, and there is
More
very
than 90%
single,
are going to
yeah,
regress.
it's a single digit which progresses. So,
Yeah. So I think this is done. We would, depending on the patient, either we can treat her. If we think she's not coming back, you can just do a cauterization of that patient. If you think she's coming back, you can call her in a year. Next slide. Now, this is a frank case of cervical cancer. What do you think she's going to present with, Nishi? Dr. Nishi? A cervical cancer presents with what usually? You're muted. You're muted.
They will come with foul smelling discharge, intermenstrual bleeding, postmenopausal bleeding for 50 years. And if she is
postcoital bleeding,
and even delayed menopause she can have if she is at the age of 50 years. She has still not gone into menopause.
Okay. So, what is the necessary cause for cervical cancer?
Ma'am, HPV infection is the persistent HPV infection actually is a necessary class 1 carcinogen.
Yes.
So apart
Yes.
from that,
So
actually
the
behavioral
necessary is HPV.
Yes.
Okay.
Yes.
Now I come to you, Supriya. How would you stage cervical cancer? Would it be clinical? Would it be by ultrasound? Would it be by MRI? What do you want? How do you stage cervical cancer?
So, ma'am, cervical cancer is now a clinico-radiopathological staging. From 2018, new cervical cancer staging, which stated it is a clinico-pathological radiological staging. So there are certain
Okay.
differences in that because we have integrated the radiology also in this thing and pathology also, and lymph node status have also been included in the staging system. So all the three modalities
Okay.
have to be integrated and then final stage has to be given.
Dr. Rimpi, would you like to add something there?
yes, ma'am. Agreed that the current this staging, it incorporates all the factors, but in most of the patients, our clinical examination assigns her a stage where you can at least decide her treatment. If it is like more than stage 2A, then I mean towards 2B, it goes for the radiation therapy upfront, and up to 2A you can plan a surgical, and that also not the bulky one, non-bulky 2A.
So that's what I'm asking you. Then this is clinical, is it not?
Yeah.
This is clinical. And
The
you can
treatment,
even
yeah.
correlate with MRI, I think, where
The
you can
treatment
get the
can be,
exact
yeah.
size.
The treatment is mostly assigned by our clinical examination, that whether we're going to proceed for chemoradiation or whether we go for the upfront surgery.
Okay. So now, do you think HPV vaccination and HPV screening in our country will actually have an impact on prevention of cervical cancer?
The big yes. The big yes.
Yes. So then what are your suggestions for implementing it? In your own practice, how will you implement HPV screening and vaccination?
So first of all, the patients who are coming to us in our OPD, we must talk of this to every patient whosoever is coming, so that even if one patient listens and goes ahead and that patient is going to convey this message. So that is what
But you would not have that much time. So you need to train some of your staff to actually, to have billboards in the OPD that this is available, this can be done, awareness things, and some staff to explain it. And then the patient comes to you, because I don't think you have the time to give half an hour to your patient.
This is one. Second is, like, we have our own club, that is a social club, Inner Wheel Club. We are arranging lectures and talks in the various schools and colleges to the girls, so that they are motivated for the awareness of vaccination, and many come also for vaccination. So,
ma'am, but supposing you go to a school, what is your conversion rate? If there are 100 students listening to your lecture,
Very
how
low.
many actually come to you for vaccination?
It is very, very low. But if we keep on hammering the things, then the things go on. So
Okay. Next slide, please. Dr. Giraddi had shown an endometriosis of the cervix. Now, if there is an endometriosis of the cervix, what would be the clinical features? Would the patient complain of anything?
Bleeding, pain during menses.
Ma'am, that could be there anyways, right? And she's already bleeding in menses.
Yes.
So what would be the clinical features? I had a patient who would come with postcoital bleeding.
Yes.
Okay. And how would you diagnose this?
So per speculum examination, we will be able to see.
So one is the suspicion, second is examination, and the third is you can also do an ultrasound.
Yes.
Okay. So how are you going to treat a cervical endometriosis?
Excision is the answer because medicines won't be helping her.
So now I'm asking all of you with your clinical experience, is it possible to have cervical endometriosis without endometriosis anywhere else?
It's unlikely. I have, ma'am, never seen cervical endometriosis.
Yes.
I've never seen. So
I have seen 2 cases, ma'am. And in one case, I had to finally do a hysterectomy because she was, in so much pain with that nodule and adenomyosis. It was associated with adenomyosis and there was a huge cervical endometrioma. So excision is the key, but the excision has to be with the root cause.
Yes.
Just removing that small nodule would not really help. Because in the cervix, you don't have enough tissue. Uska edges clear hua ki nahi, you would not even know. Next slide, please. So this is the last case. Have any of you seen cervical tuberculosis?
One case.
Even I have seen only 2 cases. So can you describe the lesion? Purvi, next slide.
it was a very fleshy kind of smooth appearing.
Please stop share.
Appearance, velvety appearance.
Yeah, it was a smooth reddish with vascularity. So we just took a biopsy thinking that some high-grade lesion will probably come up in that. But they turned out to be granulomatous picture. Then we took a excisional biopsy properly. Then they gave, it is suggestive of tuberculosis.
Nishi ma'am, aapka?
Same, the findings were there, but she was a case of infertility. So I sent that PCR along with biopsy. So, and she conceived after that, giving her ATT, and she responded to that.
So my patient was told that she has an ulcerative growth on her cervix. When I examined her, it was a smooth, shallow ulcer with margins, sharp margins. And it was shiny yellow in color. Nothing, no acetic acid, nothing would penetrate it. It was so thick. Again, did the excisional biopsy, turned out granulomatous tuberculosis, and then we gave her treatment. She was all fine. Came from a very big family and they were wild. How can she get tuberculosis? And that too on the uterus. So, that counseling and management also becomes very difficult in those cases. So with that, we are at the end of our cervix. I would request everyone present to just put on their videos for a minute. I'll take photos. And then I would like to thank everyone with one take-home message. Dr. Raju, you've been here so long. Would you like to give one take-home message?
Ma'am, thank you so much, ma'am. It was wonderful discussing all this. So my take-home message is, we have to do a systemic transvaginal sonography for proper optimization. And please don't neglect looking at the cervix. See the cervix, then the uterus, as if you do a hysteroscopy. From the vagina, then the cervix, then the hysteroscopy. Thank you, ma'am.
Sir, you have given a very good tip that you take this probe into the cervico-uterine junction. Definitely, it is going to improve the imaging of the cervix.
Thank you.
Thank you.
Dr. Shalini, Nishi ma'am, aapka take home.
Vaccination and screening, that is the most important thing which we people can do a lot in this, and we must do it.
Rimpi ma'am.
Same, what Nishi ma'am is saying, exactly same. Screening and vaccination.
I love advocating this thing to everybody, whosoever comes in by contact.
Purvi?
So every time I listen to Raju sir's talk, I'll get one small tip or learning from him. Today, I think I learned how slowly he enters the cervix, look at the anterior and the posterior lip, and looks at the polyp if it is present, putting color on the cervix. Those things I was not doing. So I think I'll start doing that, not neglecting the cervix. Yes.
And I would like to end with saying, don't forget the cervix. Look at it.
Yes.
Look at it. When a patient comes to you, don't allow her to make an excuse so that you don't get up from your chair. Get up from the chair for every patient, examine her, and I think we will be able to have an impact. If all of us everywhere can just put in a speculum, put acetic acid, at least that basic thing is the thing that's going to work for cervical cancer. Everything else comes after that. Everything.
Yes, it's very much necessary.
Yes, thank you, Sushma. If
I
you're
have
all there,
joined it.
just
I have joined
please
from
put
the
on
day.
please put on your videos. We'll take one photo and then I will say thanks and end the session.
Delegate link I have joined from 5 p.m.
But now join here.
Sitting here till now, not moving anywhere.
Okay, dear. So thank you, respected chairpersons, guests, my speakers, Dr. Raju, Dr. Rimpi, Dr. Pushpa, and the panelists that have actually participated. I thank all of you. Thank you, Purvi, for being here and, taking care of everything. Because I don't know how today I got stuck. Usually it doesn't happen, but it has happened. So thank you so much. See you again next week, Wednesday. The topic is cesarean section. Next week, we are discussing cesarean section.
I will join it. And it will
Thank
from
you.
faculty link, not from delegate link.
Okay.
Thank you, Dr. Asha.
Thank you
All
so
the best.
much.
All
Thank
the
you,
best
ma'am.
for
Thank
your
you so much.
sessions.
Thank you, Nishi ma'am.
Thank you.
Thank you.
Thank you. Please remember to vote for me and for sir.
How to do? I will vote.
Chalo. I stop sharing and we'll speak later.
Goodbye, everybody.
Good night.
Bye.
Thank you.
Good night.